think it was Murray Ross this morning who said, well, I've known him for 30 years, and I've known somebody else for 40 years, and so on. Well, I'm about to introduce somebody that I think I've known for 4 years, since we were on the Governor's Let's Get Healthy Task Force. Anthony Wright has served as Executive Director for Health Access, the statewide healthcare consumer advocacy coalition, since 2002. And if you read the LA Times or the Orange County Register, you're bound to see his name about every other day. And I won't comment on that, Anthony. Anthony has led fights to pass a first-in-the-nation law against hospital overcharging the uninsured and to win a prescription drug discount benefit despite an $80 million lobby against it. His background is as a consumer advocate. He's very good at it. He worked for New Jersey Citizen Action and the Center for Media Education. Anthony Wright has a lot to say about access. Let's hear what it is.
Okay, so good afternoon. Again, my name is Anthony Wright. I'm the Executive Director of Health Access California. We're the statewide healthcare consumer coalition working for the goal of quality, affordable healthcare for all. I'm really pleased to be here. We work on everything from passing the HMO Patients' Bill of Rights to bills around stopping unfair prices with regard to hospitals or prescription drugs, and did a lot of work leading the grassroots effort to pass the Affordable Care Act. And so I just want to ask this question because I want to know my audience here, because I'm in California, but I'm also in Orange County. So how many people are in the repeal and replace camp of the Affordable Care Act? Raise your hand. It's okay. How many people are in the implement and improve category? All right, so I appreciate that. I have the right slides then. So I guess I just want to talk about the work here in California to do it and what we need to move forward with. But it always has to start with the Affordable Care Act and what a big deal it was. It was the biggest thing that Congress had ever passed with regard to consumer protections, with regard to coverage expansions for 2 decades since the creation of Medicaid and Medicare, and with regard to dealing with cost and quality. As a consumer advocate, I could give you a list of 10 things that we advocated for it to go further or more or different, and we didn't get it. But we're also grading on the curve of Congress. No offense, Wendell. And so this was a big deal. But in the words of a famous reality show host, it's up to the states to make it work. That it really is at the state level that it is either going to happen or not. And California had a lot of pressure on it. People said that the stakes couldn't be higher in California. We're the test case for California. The ACA can't succeed if California fails. So we also had a particularly difficult challenge in that we actually had one of the most acute problems with regard to uninsurance in our healthcare system in the country. If you look at all these states here, these are the top 10 states with the highest uninsured rate prior to the Affordable Care Act. Every single one of them has a Republican governor except for California. And so what has happened is that we've had one of the biggest drops in the uninsured, and obviously some of those other states have not taken advantage of that opportunity. But California has had to uniquely, it's nice that New York or Massachusetts did these reforms. Massachusetts, we had more uninsured than Massachusetts had people. Another thing about Massachusetts, we started with 20% uninsurance. We cut it half to about 10, 11%. That's where Massachusetts started with Romney Care. Before they even passed Romney Care, they got it down to 2 or 3%. So all the work that we've done to implement Affordable Care Act, we've basically gotten it to pre-reform Massachusetts. So a lot of work to still do. But we've been doing it partially because we've been implementing it, cutting the number of uninsured in half, providing new financial assistance and consumer protections to people, having a relatively low rate of increase in premiums, 4.2% average for the last 2 years in covered California. We've been doing that partially because we've taken upon the platform of the Affordable Care Act, but taken additional steps. We implemented it early. We did the Medicaid expansion a couple of years earlier than the rest of the nation, using county dollars to start up low-income health programs. We started some of the consumer protections earlier, but also also better. The exchange, for example, is one of the few in the nation that actively negotiates on behalf of the now 1.5 million people in the exchange for the best possible value. It also standardizes the benefits so that your Health Net plan and your Anthem Blue Cross plan are, the silver plans are the same, the gold plans are the same, so you can actually have apples-to-apples comparisons, actually have vigorous price competition. And actually, just today, as we speak right now, in the Covered California board meeting in Sacramento, they're introducing some quality metrics that will also be part of those negotiations to drive a improving quality agenda as part of it. That's a really important part of what California is doing to take the platform of the ACA go further. We've also been aggressive about outreach with regard to certain populations, whether it be the LGBT population or our diverse applications. So the question is, what's next? One thing is that we still need to make it easier to sign up. It still can get complicated. We still have glitches in the system. And when California has a glitch, you know, it's a glitch. I mean, we had a backlog that was 900,000 people in the first year of implementation, which is bigger than some states' whole Medicaid programs. There's still we have a 24-month roadmap that continues, that doesn't seem to end. It just keeps going because there's more things to add at the end about how to improve our systems. One thing we would really like to do is just get rid of a glitch in our enrollment systems with regard to estate coverage. We're one of only 10 states that require people to over 55 that if they sign up for Medi-Cal, they're actually signing a estate recovery portion that could claim the family home when they decease. And most other states limit that to only long-term care. We have to really fix that in our budget, and that's one of the things we're going to seek to do in the next budget year. But the other work that we have to do is to try to get everybody included. Cutting the uninsured in half is great, but there's still more to do. You have here some projections by UC Berkeley about the fact that even though we had about 7 million uninsured, let's say we do an okay job, we'll have about 3.5 million remaining uninsured. If we do a really great job, less than 3 million. But there's still going to be a significant population of folks who are uninsured. That will include, obviously, the undocumented. That's a good portion of and they're explicitly excluded by the Affordable Care Act, but also folks who are eligible for subsidies but don't sign up. Maybe that's an issue of outreach. Maybe that's an issue of affordability. There are some issues like a family glitch where if somebody who has employer-based coverage, they can get coverage from their employer, but if they don't get, their family can't go into the exchange. If they don't have employer-based coverage through their work, they don't have access to the subsidies either. That's a thing that needs to be fixed. Some people might need more help with regard to affordability. But so what is left for them if they are not covered by the new structures of the Affordable Care Act? It's the current safety net, which is emergency rooms, is clinics, but it's also the fact and reason why we've gotten into this in the first place, which is that if you're uninsured, you live sicker, you die younger, you're one emergency away from financial ruin. There is counties have often been the last bulwark with regard to a safety net, and the issue, however, is that counties interpret that responsibility very wildly, both in terms of income and in terms of immigration status. For example, this time last year, the blue counties were the only counties that actually covered folks who were undocumented in their indigent care programs. The rest of the counties did not. Now, there was some exciting opportunities happening under the Affordable Care Act with regard to the fact that because we are now covering new populations, some counties were looking to how can we then take our existing safety nets and reorient them to the remaining uninsured. If I was here last year, I would have said that we would have gotten maybe one or two of the 3 counties that stopped providing undocumented care in 2009 during the recession. We would have gotten 2 or 3 of them to switch back to covering that population and being more inclusive in their safety net. The good news is the map looks now like this, that several counties, Sacramento, Contra Costa, Monterey, and 30 counties in the CMSP program have taken steps to do limited benefit pilot programs to try to include more people in the safety net. And I would predict for next year that a handful of other counties will add to that list, especially some big counties, because of the new opportunities under the Medicaid waiver to flexibly use some dollars to have a more inclusive as well as smarter safety net. I think San Joaquin, Riverside, San Bernardino, Ventura, others might be in that category. So we have taken steps toward the goal of health for all, especially with regard to the undocumented, both with regard to expanding public safety net programs. As Howard said, we had a major victory this year, a campaign that we co-led with the immigrant rights movement on the issue of covering all children, regardless of immigration status, in our Medi-Cal program. We fundamentally believe that immigrants are an important part of our society and our economy. They should be included in our health system as well, and that makes our health system stronger for all of us. We think that we also believe that if President Obama's executive order goes through with regard to expanding deferred action status, that those folks would be eligible for Medi-Cal coverage as well. And there is a pending bill, SB 10, that would take additional steps, including seeking a waiver so that people could buy, without subsidy, but with their own money, buy into covered California, because right now that's an exclusion under the law. And so that bill is pending. And we do think that even the issue of trying to expand further coverage in Medi-Cal is actually something that is financeable. There has been studies, including by your UC colleagues, with regard to the fact that there's a lot of offsets and reasons in the system where you can make this make financial sense. So, but to broaden it out back to Medi-Cal, the base program, there's still other funding issues that we need to address, especially with regard to the cuts that were made during the Great Recession, 2009, 2010, with regard to benefits. 10 benefits were cut for Medi-Cal, everything from dental to podiatry to psychology, division. Those were, only dental coverage was partially restored. There's still, those things are still basically denied to most adults on the Medi-Cal program. And then the issue of rates. Medi-Cal in California traditionally has very low rates, as both of our prior speakers have talked about. There is a need to restore those rates, especially from the cuts that were made in the Great Recession, but even prior to that. And then the question is, how do you do that? Our governor is not interested in making broad across-the-board increases, but we do think that there is an appetite to take a look at if there is a real access issue. Again, both Howard and Chris talked about some of the real access issues, both in terms of, and how that's reflected in terms of our payments. The fact is, if you don't pay doctors tons, then less will sign up to actually care for this population, and we are at one end of the spectrum with regard to our payments. And that has an impact on the access that people in Medi-Cal have. I want to be clear, people who are on Medicaid, and just like the satisfaction survey that Chris indicated, people on Medicaid are very appreciative of it. It's an incredible lifeline, but there are very real access issues. So our agenda has been, how do we address this in a meaningful way? And I think it's a combination of both accountability and investment. This is not just about in Medi-Cal. Issues about networks are about, not in Medi-Cal and covered California, in the plans that most of us have through employers. Can you get access to the doctor you need when you need it? Howard was right. It's not enough just to say, oh, is a doctor assigned X number of patients? The metric that we believe in is the one of timely access. And I know my colleague Cindy Ennis, when she was a regulator at Department of Managed Healthcare, worked to put in some very important rules that said you have a right to get in to see a doctor within 2 weeks, or whatever depending if it's urgent care or specialist care, to set amount of time. That's how you experience it, and the question is, how do we then monitor it? And so we've passed laws in the last 2 years to try to make sure that there's an annual survey of network adequacy and timely access by product line, so that we really find out what's going on with this, and then also on provider directories. Frankly, in a Medicaid program, or if to the extent that you're paying customers, we're paying the plan to guarantee that we are going to get the access we need when we need it. If we're not doing it, then it's a fraudulent transaction. And so that's the basic consumer protection that we need to make sure the plans are accountable to provide that access, since that's what they're accepting payment and promising to do on behalf of it. And in terms of provider directories, that's been one of the big issues. in covered California, there was an issue with regard to a lot of complaints about narrow networks. There was a survey done by Department of Managed Healthcare that found that 25% of the two leading insurers, Anthem and Blue Shield, 25% of their provider directories were inaccurate, either doctors that didn't exist at the location that were listed, or that those patients say that they weren't there. So then that's an issue that we are seeking to address as well in legislation, and there will be bills there. So there has been a policy response by regulation, investigation, negotiation, litigation, and legislation. So I talked about the access issues, and so let me close by talking about the fact that if we do identify, and I suspect we will, specific real access issues, then what is the revenues needed to help address those issues, to have the investment, to attract the providers to provide the care. And so we are supporting 3 different revenue approaches this year, which I think hopefully all 3 will be successful. One is going on as we speak. The reason Jennifer Kent from the Department of Healthcare Services is not here is because of something called the MCO tax. It's a way to draw down dollars from the federal government. Hopefully that will be resolved in special session in the next week or 2, but it's basically a way to draw down federal dollars. The two revenue sources that I think would be of interest to this group is the ones that you will be deciding on yourselves on this fall's ballot. One is a extension of existing dollars with through the Prop 30. California voted to tax itself to get out of the recession and not cut school days and through an upper income and sales tax. There will be a proposal on the ballot to extend Prop 30, not the sales tax. It will let the sales tax go away, but extend the upper income tax bracket increase for many years. So not a tax increase, but just an extension for the upper income set. And that is, and if we can do that, that will prevent additional cuts and actually perhaps give some ability for us to have the investments in education as well as healthcare. Remember, at the end of the day, state budgets do only 3 things. They educate, they medicate, and they incarcerate. And healthcare is a big part of that. And then the final thing that I would mention is on the tobacco tax. There will also be a measure on a $2 raise in the tobacco tax. We used to be a leader in the tobacco taxes. We used to be a leader in reducing youth smoking. Our tobacco taxes now, because other states have updated their tobacco taxes, actually 48 states have updated their tobacco taxes since the last time we updated ours. We're now 35th in the nation, well below average in terms of our level of tobacco tax. That tobacco tax would raise $1 billion to invest in Medi-Cal and Medi-Cal rates, and it has a very strong coalition. So we do expect that, especially that tobacco tax will have an active opposition from the tobacco industry, and they have been able to defeat 2 other tobacco taxes in prior years. But this year, in a presidential year, with a strong coalition behind it and with the right funding, we think we can get that done. If we can get that done, then I think we have the opportunity to make some progress this year in the budget on some of the restorations, but really have then the opportunity over the next couple of years to really restore our healthcare system with the investments needed to really serve those 12 million people and be a bulwark and a pillar for the healthcare system on which we all rely. And with that, so I hope that gives you some sense of the budget and healthcare issues that we're dealing with in Sacramento, but they're not all in Sacramento, and as I've made clear, some of these policy decisions are going directly into your decision hands this November. Thank you.